everyone. This is Dr. Purvi Chawla. I'm logged in live from the ATTD in Florence, Italy, the beautiful city of the legendary artist Michelangelo. He was born here and spent most of his life here. And what a coincidence. Yesterday was day one of ATTD, the Advanced Technologies and Treatments for Diabetes meeting, one of the most well-organized and really advanced meetings in our field. And also the birthday of Michelangelo, 500 and something birthday of Michelangelo, and we were right in this city. So a really special moment for all of us. So today I'm very thankful to the organizers for having this update being relayed live from here. And very, very happy to share some of the information that we collected as well over here. Very charming meeting, lots of networking, amazing players, as Dr. Jyoti Dev also mentioned, and a lot of things looking up for India as well. So without much ado, let me dive into the first day update from ATTD. Excuse me. As you can tell, the weather is really cold and I have got a cough. However, so the update is going to include the SURPASS-6 trial results, Tirzepatide versus insulin Lispro, that were compared on a background of basal insulin in patients of diabetes uncontrolled. And then a very interesting proposition from the IDF, the position statement on the 1 hour post-load plasma glucose for diagnosing intermediate hypoglycemia and type 2 diabetes, and then the cardiorenal outcomes in diabetes patients after intensifying therapy with empagliflozin as a triple drug therapy regimen for 18 months. And also a good comparison of blood sugars, HbA1c, and lipids in diabetes versus non-diabetes individuals. And the last two are posters, and I'd like to share that information with you. But first, we go on to this wonderful session by Julio Rosenstock, the very big expert who has, been part of the entire Tirzepatide clinical program, so to speak, and he presented the SURPASS-6 trial that compared Tirzepatide, which is a dual GIP-GLP receptor agonist, versus insulin Lispro added on to basal insulin in patients of diabetes. So let's look at the background first of all. We know GLP-1 receptor agonists are recommended as the first injectable therapy, but basal insulin, as per tradition, is still very widely used. Nothing wrong with that. First, due to, of course, the lower cost as compared to GLP-1 receptor agonists, reimbursement issues, and then prescribing habits themselves. Real-world initiation of basal insulin was quite stable between 2014 and 2020, despite an increase in the use of newer GLP-1 receptor agonists and SGLT2 inhibitors that have even flooded the Indian market because of loss of patency. An estimated 40 to 50% of our people with diabetes, despite all these approaches, do not achieve optimal glycemic control, as we know and have experienced when treated with oral medications and basal insulin as well. GLP-1 receptor agonists and the dual GIP-GLP receptor agonists, when added to basal insulin, have shown clinical benefits, and I'll just review that in a minute. So if you look at this, these are the HbA1c changes that have been achieved with combining GLP-1 receptor agonists that are already in the market and as seen in the trials conducted before. So if you look at the first block, which is insulin glargine plus exenatide given once weekly, or the AWARD-9 trial represented in the second block with insulin glargine and dulaglutide given once weekly. And then you have the SUSTAIN 5, which is with basal insulin and semaglutide injectable Both doses, 0.5 and 1 milligram tested in addition to basal insulin. And then you have the Pioneer 8, which is basal insulin plus the oral semaglutide given at 3, 7, or 14 milligrams every day. So you can see that there has been significant, clinically significant and statistically significant reduction in HbA1c with each of these, and right from 1% reduction to almost 1.8, the highest achieved by semaglutide, 1 milligram, which is injectable given once weekly in addition to basal insulin in these patients. So this is very significant finding and something that we remember. Next is looking at the body weight changes, and again across these same trials you can see there has been a beautiful dose dependent reduction in weight as well, where right from 1 kilogram to almost 6.4, which has been with sema injectable 1 milligram given once weekly despite the use of basal insulin in the background. So this has been again a clinically significant finding. Now looking at Tirzepatide, which is the only dual GLP receptor agonist available right now. And you can see that the HbA1c changes at week 40. Again, the 3 dose levels of Tirzepatide, 5 milligrams, 10 milligrams, and 15 milligrams given once weekly, as compared to placebo, have resulted in a more than 2% reduction in HbA1c. The highest being with the higher 2 doses of Tirzepatide at 2.6, which is extremely impressive. And again, this is the only dual GLP receptor agonist that's available. So just reviewing the ADA 2024 recommendations on advancing basal insulin, we know that first we have struggled with initiation of insulin itself. But as we initiate, we know we all, because of the poor control achieved in almost 50% of our patients, we need to optimize therapy, insulin therapy, and then even intensify. So what does the ADA say? That the patients may be on a background of metformin with or without SGLT2 inhibitors, and basal insulin may be ongoing. And despite achieving fasting plasma glucose targets with basal insulin, or if basal insulin dose is more than 0.5 units per kg per day, then they are not controlled, and we need to again add an agent or intensify therapy. What are the options here? Excuse me. They do not recommend switching to premix insulins like the rest of the world. We know many organizations don't do that. But however, there's a clear recommendation that either we add the prandial insulin and to begin with at the main meal itself, and then adjust as per the algorithms and move on to a complete basal bolus regimen, or alternatively add a GLP-1 receptor agonist, or even the GLP-1 GIP receptor agonist that is available in the US and other countries, not in India though, or even we can switch to a fixed ratio combination or co-formulations. We could intensify with that. But so this is a recommendation from ADA, and let's look at what SURPASS-6, how does it really add up to everything here. So the overall baseline characteristics, and let me just quickly remind you, SURPASS-6 was a trial that compared patients of type 2 diabetes who were uncontrolled on baseline OHAs plus basal insulin and were randomized to receive either Tirzepatide at the 3 doses given once weekly, 5, 10, or 15 milligrams, and or to a complete basal bolus regimen with insulin Lispro, with the continued oral agents as well as basal insulin. And the baseline characteristics include The total of 1,425 subjects, of which 58% were women and 42% were men, with an average age of 59 years at baseline and diabetes duration of 14 years, body weight at 90.5 kilograms, BMI at 33 kilogram per meter square, and a baseline HbA1c of 8.8%. Predominantly, or 85% of these patients were already on metformin, and there was a small percentage where pre-trial sulfonylureas and DPP-4 inhibitors were also used. These patients had an average fasting glucose of 157 milligrams per DL, despite daily glargine dose of 46 units or corresponding to 0.5 units per kg per day. So they do meet the criteria for the trial, and they were further intensified either with tirzepatide or insulin Lispro. Daily use of insulin over time, and you can see that the insulin glargine was, the average use was 42 units at the end of the study, and insulin Lispro was gradually titrated up to almost 62 units per day, which corresponds in the Lispro arm, glargine has been up titrated to 62 units per kilogram, which is a pretty high insulin dose at the end of the study. However, the lower dose of glargine was, the dose was much lower in the tirzepatide arms, as you can see in the graph. Looking at the HbA1c changes over time, you can see again, if you follow my arrow here, the dotted line, you can see that's the insulin Lispro arm. There is a definite reduction in HbA1c from the mean of 8.8 at baseline. It's come down to almost 7, and then somewhere it steadies itself up to week 52. However, the tirzepatide arms, you can see there's a lovely reduction in HbA1c. It's significant right from week 4 to week 8, week 12, and over 52, it has even come down to below 6.5% of HbA1c level, right from 8.8. So this has been quite significant, and if you track these bars, you can see that insulin Lispro caused a 1.2% reduction in HbA1c over at the end of week 52, and tirzepatide arms on an average were responsible for reducing HbA1c by 2.3%, and with a beautiful dose-dependent reduction seen with tirzepatide. As far as proportion of patients who achieved their target HbA1c of, say, less than 7%, on an average, the tirzepatide arms fared better, with 72% of individuals reaching the target HbA1c goal of less than 7, with only half, or 37%, in the insulin Lispro arm reaching the target HbA1c of less than 7. In fact, the trend continued, and there's a very substantial number, almost 20% of tirzepatide arms, where they have achieved an HbA1c of even lower than 5.7%, as compared to just a handful, or 2.3%, of individuals in the Lispro arm going that low, below 5.7% HbA1c. Again, this has been a very significant finding, tilting in favor of tirzepatide, or the dual GIP/GLP receptor agonist available today. Body weight changes over time and at week 52 have also been quite consistent with what we would expect. This line above the 0 is the insulin Lispro arm, and you can tell that at the end of 52 weeks, there's almost a 4 kg increase in weight in these individuals, whereas a dose-dependent decrease or reduction in body weight from baseline has been seen, going all the way to up to 12 kilograms. So if you track this here in the bar diagram, you can see there's a 3.8 kg increase in weight in the Lispro arm, whereas up to 12 kilograms or an average of 9.6 kilogram body weight loss with the Tirzepatide arms. Well, again, almost 75% of the individuals in the Tirzepatide arm have achieved at least 5% weight loss, and more than 50% have even achieved more than 10% of their body weight loss in the Tirzepatide arms, or even almost one third of the individuals, which is 30% of the individuals on an average, have lost more than 15% of their baseline body weight as compared to a mere 0.3 with insulin Lispro, which is negligible. So you can see that despite the use of basal insulin, there has been a substantial number of individuals losing weight and losing even clinically significant weight as compared to the insulin intensified regimen with basal bolus regimen. So in summary, Tirzepatide has significantly improved HbA1c as compared to insulin Lispro, with 49% to 70% achieving target HbA1c of less than 6.5, and 31% of Tirzepatide 15 milligrams achieved a target HbA1c of less than 5.7%, almost unheard of with insulin. On an average, we know Tirzepatide groups have lost almost 10 kilograms of their body weight loss despite being on basal insulin, and with a body weight gain in the Lispro arm of almost 4 kilograms. The insulin glargine use also reduced in the Tirzepatide arms as compared to the insulin Lispro arm, where it was up-titrated to almost 62 units per day, corresponding to 0.7 kilogram units per kilogram per body per day. Clinically significant hypoglycemia was again noted in the insulin Lispro arms, and 10% lower incidence was seen in the Tirzepatide arms as compared to the insulin Lispro arm. And overall, the patient-related outcomes, including physical as well as mental component summary scores, were much better in the Tirzepatide arms as compared to the insulin Lispro arm. So in conclusion, Dr. Rosenstock clearly said that Tirzepatide has demonstrated superior HbA1c and body weight reduction associated with substantially less clinical hypoglycemia and much less insulin use overall, resulting in improved SF36V2 scores, which indicate good patient-related outcomes, supporting a potential role of Tirzepatide as one of the preferred standards of care for further therapy to improve the glycemic control in inadequately basal insulin-treated diabetes patients. So you see, if somebody is on OHAs and basal insulin, a good way to intensify the therapy and achieve target HbA1c as well as body weight goals would be to the addition of either a GLP-1 receptor agonist, which is accessible to us in India, even though expensive, or to use a dual GIP-GLP receptor agonist as proven in this trial, SURPASS-6. Excuse me. The next update is a very, very interesting one, and I'm going to talk about the IDF position statement on the 1-hour post-load plasma glucose for the diagnosis of intermediate hyperglycemia and type 2 diabetes. This was beautifully navigated by Dr. Michael Bergman, and let me just give you the background for the same. So the current criteria for diagnosing intermediate hyperglycemia or forms of pre-diabetes are quite discordant across the world, whether it's the ADA, WHO, or the American Association of Clinical Endocrinologists. They all define impaired fasting glucose quite differently. And even though they may have some agreement on impaired glucose tolerance, again, the HbA1c criteria that they use for defining pre-diabetes are again different. Thus, we have at least 5 different glucose and HbA1c criteria as per these bodies, And there's a complete disagreement between WHO and ADA in terms of impaired fasting glucose and again HbA1c, which leads to confusion and complexity, and would probably aim at getting a consensus to define precisely what is intermediate hyperglycemia and what is the risk of converting to diabetes in these patients. HbA1c, even though it's used widely, is insensitive, again discordant with the glucose criteria also, and has a large variation across the world due to either geographical reasons, genetic reasons, ethnicity, age, and medical conditions that may coexist. So these are the limitations that we have in the current criteria. And I'm very interested in sharing this new information that we have today. So identification of glucose thresholds for incident diabetes by physiologic analysis has been done with using a mathematical solution. So all those of us who thought that by taking medicine we would go away from mathematics, here we are, back to maths. So the constraint optimization algorithm identifies minimal glucose levels associated with the maximized combination of insulin sensitivity and beta cell function. So just look at the box and this will become clearer. The optimized fasting glucose levels are in those who are less than 45 years of age. Women would be at least 87 or less, and men would be 89 milligrams per DL or less. If you are above 45, these thresholds correspondingly would be 92 and 95. The corresponding optimized 2-hour glycemia levels are also much lower than what we conventionally use if you just glance at these figures given here. Now, some more details. The present analysis demonstrates that the plasma glucose levels associated with the best individual combination of insulin sensitivity and glucose sensitivity are substantially lower than the conventional diagnostic thresholds for fasting plasma glucose and 2-hour glucose levels, and that subjects with non-optimized glycemia are at increased risk of progressing to diabetes. So what this essentially means at that the criteria that we've been currently using are all right to predict diabetes or conversion to diabetes, and that's what pre-diabetes is all about. However, there are more refined criteria like the 1-hour post-load glucose levels, which combine insulin sensitivity and glucose sensitivity thresholds, but these are much lower than the conventionally used 2-hour or fasting or HbA1c levels to define prediabetes. Now let's look at the evidence. You can see that the journey from normal glucose tolerance, which is right here, normal glucose tolerance represented as NGT, to type 2 diabetes is a long one, and somewhere along is pre-diabetes or intermediate hyperglycemia that we conventionally define. And pre-diabetes, when that is, when HbA1c is by ADA would be 5.7 to 6.4, or an impaired fasting is between 100 to 125 milligram per DL, or again by ADA, or an impaired glucose tolerance is between 140 and 199 milligrams per DL. All these are targets for intervention in order to prevent the progression to type 2 diabetes. So this is the area that we've been focusing on, and this is what we've been using to stop or intervene in terms of to stopping the progress to diabetes. However, what is being proposed is that let's use the 1-hour post-load glucose values and identify these high-risk individuals right here itself so that we are able to intervene aggressively and stop the conversion or progression to diabetes or even pre-diabetes for that matter. So this is a proposed new target for intervention. Excuse me. The historical perspective of 1 hour post-glucose has been well defined in several posters and several publications right from in the last 15 years or so. And majority of the work has been done by Dr. Abdul Khani and team. And you can see really a lot of diabetes experts involved in the same. So what did the San Antonio Heart Study tell us? It told us that if the threshold of 155 milligrams per DL or 8.6 millimoles per liter is crossed at 1 hour post-load, then that would predict the risk of diabetes over 8 years with greater sensitivity than a fasting level or a 2 hours post-glucose level or an HbA1c at the same point in time. So this is a substantial finding from this study, and let's see what others, how they have gone about it. Again, the frequency of 1 hour post-load glucose of above or of at least 155 milligrams per DL or more among individuals with different glucose tolerance conditions. And it's said that even with the normal glucose tolerance as defined conventionally, if the 1 hour post-glucose load value is high, 25% of these patients are going to develop diabetes. So 25% of them do have that high 1 hour glucose despite having normal values of fasting, 2 hours post-glucose load, as well as HbA1c. Prevalence of this 1 hour high post-glucose load increases progressively with worsening glycemia. And this was the main finding of the Katamari study, which was published in Nutrition, Metabolism, and Cardiovascular Diseases in 2016. So 25% of those with normal glucose tolerance, or even 57% if they had only impaired fasting glucose. And again, with impaired glucose tolerance, the percentage increases. But if they had both, then there was almost a 94% increase to diabetes. And in terms of diabetes, if somebody had 1 hour post-glucose load increase, that would be almost all diabetes patients would have that raised value at 1 hour post-glucose load. Most of these patients have been studied in diabetes prevention trials without us knowing really the importance of this 1 hour post-glucose. And lifestyle interventions should be very effective in preventing further progression of diabetes. So again, this meta-analysis looking at the 1 hour post-load glucose, which is high, across have shown us that individuals with 1 hour high post-load glucose should be diagnosed even before the occurrence of the conventionally defined pre-diabetes. So what I'm trying to say is catch them early, nip it in the bud. Before it even progresses to pre-diabetes, we have this wonderful value that we can look at for screening our patients and then deploying really aggressive lifestyle changes in these patients, thus preventing the progression to diabetes. Again, this has been quite substantial for detecting the risk of diabetes in diverse populations. And this particular study clearly shows us that this was across 16 studies, almost involving 35,000 individuals and follow-up of average 16 years. Populations include almost the entire world, whether it's Asians, Europeans, US, Israeli. It's a diverse amount of people with different ethnic backgrounds that have been included in this study. Excuse me. And the analysis clearly shows the correlation between this 1 hour post-glucose load value of more than 155 milligrams per DL and the correlation with adverse outcomes right from insulin resistance to obesity to abnormal lipids or coagulation or even subclinical atherosclerosis, inflammation, vascular stiffness, cardiovascular disease, so on and so forth. So the biological evidence does demonstrate that high 1 hour post-glucose load, even in individuals that have normal glucose tolerance, is associated with subclinical inflammation and also subclinical target organ damage. Thus, the worsened metabolic and atherogenic profiles could explain the increased risk of cardiovascular disease and mortality in these patients. This particular study, the MPP or the MARMO Preventive Project, looked at the prevalence of retinopathy and peripheral neuropathy in these patients who were with normal glucose tolerance, but they had 1 hour higher values of glucose, more than 155 milligrams per DL. And you can see that whether it's retinopathy or even peripheral vascular complications, the hazard ratio is pretty high in these patients as compared to those with as compared to those who did not have these raised values. And the risk is much worse if they have not only the 1 hour higher value, but also impaired glucose tolerance, which means even the 2 hour post-glucose load values are increased. This risk is much, much higher than those with normal glucose tolerance and 1 hour raised values. Similarly, the mortality as seen from the Israel study of glucose intolerance, obesity, and hypertension, or GOH, again, it clearly shows that individuals at risk for developing diabetes could be identified earlier using the 1 hour threshold value of 155 milligrams per DL, which could avert progression to diabetes and increase mortality. So, in this study also, they compared the 1 hour versus 2 hour raised values, and they found that 1 hour more than 155 milligrams per DL predicts mortality when 2 hour post-glucose is less than 140 milligrams per DL. So even when the 2 hour value is normal, the 1 hour can predict mortality. And again, the combination of 1 hour raised and 2 hour raised, or 1 hour raised and IGT or impaired glucose tolerance, does predict the greatest mortality risk. And thus we can identify these high-risk individuals even before they develop any pre-diabetes that's conventionally defined. So the overview is that the definition of high-risk diabetes in adults, children, and youth can be helped by when we looked at this 1 hour post-glucose load value, and if the threshold is more than 155 milligrams per DL, this should be considered as intermediate hyperglycemia. It's associated with worsened metabolic and atherogenic profiles. It also identifies a risk for micro and macrovascular complications and also mortality. It's equally correlated with obstructive sleep apnea, CFRD, MAS-SLD, and severity of hepatic fibrosis. I've not shown you that data, but this correlation does exist. Occurs before the onset of impaired glucose tolerance, merits identification before IGT can occur. It's very, very cost effective for high-risk screening because it provides us with an earlier detection and intervention opportunity, and it may benefit from lifestyle and pharmacological interventions to reduce this progression to diabetes and reduces the diagnostic complexity and confusion with the current criteria, with so many associations giving different thresholds. When the 1 hour post-glucose load value crosses 209 milligrams per DL, that's the definition of diabetes as per this particular value. So it is validated that we screen high-risk population using the validated questionnaire like the FINRISK and ADA questionnaires. The high-risk population should also undergo laboratory screening as given. People with a higher 1 hour post-glucose load value the threshold being 1.155 milligrams per DL, are considered to have intermediate hyperglycemia and should be prescribed lifestyle intervention and referred to a diabetes prevention program. And again, people with 1 hour post-glucose load value of more than 209 milligrams per DL are considered to have diabetes and should have a repeat test to confirm the diagnosis of diabetes and referred for further evaluation and treatment. So this was all about the IDF position statement. And now very quickly, I'm going to review two good posters that we came across. One is looking at the cardiorenal outcomes in diabetes patients after intensification with treatment with empagliflozin as a triple drug combination for 18 months. So again, diabetes we know is associated with a high incidence of cardiorenal adverse outcomes, and again we need to reduce the impact on the progression, impacting hospitalization and organ damage in these patients. In diabetic population, glycemic control is fundamental to this treatment. And SGLT2 inhibitors, we know that have shown definite benefit in terms of controlling cardiovascular risk factors. So the objective of this particular study was to evaluate the efficacy of intensifying with empagliflozin as part of a triple drug therapy regimen and its relationship with cardiorenal outcomes over an 18-month period. This was a retrospective cohort, and it included adult patients with diabetes diagnosed according to the ADA criteria between Jan 2021 and April 2023. They were treated with SGLT2 inhibitors in a triple combination with GLP-1 receptor agonist, DPP-4, sulfonylureas, or basal insulin. So these were the different combinations they had. And then a statistical analysis was conducted to see the rates of hospitalization, even changes in the LVEF, and so on and so forth, looking at the cardiovascular and renal outcomes. And what did we find? That a total of 42 patients were included, 20 were women and 22 were men, and 43.3% were more than 60 years in age, while predominantly 56.7% were less than 60 years of age. It was found that the first hospitalization for heart failure occurred in 2 out of 42 patients, which is 4.76%. The ejection fraction as measured by 2D echo was a mean of 57.2 in non-hospitalized patients and 36.5, which is much lower in the hospitalized patients. And this difference was statistically significant and as well as clinically significant. At 18 months, there was a significant difference in the HbA1c itself between hospitalized and non-hospitalized patients, where the non-hospitalized patients were nearly at target with 7% HbA1c and non-hospitalized at 7.5% of HbA1c. But there were no significant differences at the end of 18 months in terms of microalbuminuria in between these two groups. So the study highlighted the importance of the choice of drug therapy in patients with diabetes and the choice of the same. The glimepiride metformin empagliflozin combination and the semaglutide metformin and empagliflozin groups demonstrated significant improvement in metabolic control with improved HbA1c, weight loss, and that could probably influence lower hospitalization also in these arms. In addition, HbA1c and microalbuminuria were found to be significantly associated with hospitalization, underscoring their importance as risk markers in patients with diabetes. The last one was again a very interesting poster because diabetes, as we know, affects 5% of our population, and it's related to genetic and environmental factors and often coexists with dyslipidemia and increased cardiovascular risk. Many complications of diabetes are associated with the glucose and triglyceride metabolism, and the aim of this study was to determine the glucose and the lipid profile levels as well as HbA1c in diabetes versus non-diabetes patients. Altogether, 80 participants of the study were included and all the samples were taken and analyzed. Of course, there were non-diabetes patients as control in the same. They found that there was a statistically significant difference in the median values of the 6 variables that they assessed in diabetes patients as compared to non-diabetes patients, men and women separately. The 6 analytes that they looked at were glucose, HbA1c, total cholesterol, HDL, LDL, and triglycerides. So the current study in the Greek population showed an increased levels of cholesterol, HDL, LDL cholesterol, triglycerides, and HbA1c in the plasma of diabetes group patients. And these combinatorial of sugars, lipids, and HbA1c significant elevated values within the diabetes group is definitely indicative of future metabolism, metabolic syndrome, and high risk towards other abnormalities like the cardiovascular disease. So with that, I complete my update for you from day one. And I think it was very interesting to listen to Dr. Jyoti Dev sir also. And I hope you all have enjoyed. So good evening. Thank you for logging in this late in the night in India. But it's been a fantastic meeting and see you all soon.